त्वं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Yeah.
Thank you, Arul. Now I request Dr. Prabha Madam, the chairperson for Endoscopic Committee, to give a brief welcome.
Yeah. Very good evening, everyone. I'm really lucky to conduct this second talk of the series, Evening with the Endoscopy Experts. And we are trying to choose topics from basics to advanced in this topics in the field of gynae endoscopy. So for that, whoever suitable and who are good in that topic only we are choosing. And I have made an effort to bring, companies who are producing these equipments and know better about those products with the person who is manufacturing also. That's why I'm involving the product manager also for these talks. So this is one small change we have made from the routine traditional webinars. Okay, last time also we have included the Karl Stoss person who has given a wonderful insight about the camera systems, and this time I hope from Bhanupriya she will also give the insight about the electrosurgical unit maintenance and monitoring, because those all are the practical things which we usually miss while attending our conferences and the clinical meetings. And I'm happy our Durgadas Asrana sir, president, he is always supportive to us to go ahead and given a lot of freedom to conduct the webinars and this thing in KSOGA background. Also, I welcome Dr. Shubha Godi madam for taking out the time, and she is here to encourage us for our second webinar. And I welcome all the speakers. You will get a introduction of those speakers and all the chairpersons and all the delegates and team members who are joined. Hello.
Yeah, ma'am, your voice was breaking in between. Yes. Yeah, thank you, Prabha ma'am. Now I extend a warm welcome. Yes, ma'am.
Yeah.
Now I extend a warm welcome to our president of KSOGA, Dr. Durgadas sir, and request you to please share your presidential address.
Good evening, everybody. First of all, I congratulate Dr. Prabha, Dr. Priscilla, and the whole team of Endoscopic Committee by taking this program in a very, very methodical way, very systematic way. This is what I wanted. Like, everybody, now the laparoscopic surgery is picking up like anything. But we are losing the basics like maintenance of the instruments, or how to use cautery, those things which I wanted to everybody to know. And Dr. Prabha is taking the course in such a methodical way. Really, I should appreciate her for this venture. I respect and acknowledge the stalwarts of today evening who are from out of Karnataka: Anurag Bhate, Dr. Yamal Patel, Miss Bhanupriya, and my dear friend Dr. Subhash Malya. Even though all you are so busy, for our sake you have found time and you have joined us. Thank you very much. And I thank all my colleagues like Dr. Prema. You may not be knowing, Dr. Prema was my junior in KMC Mangalore. We share so much of, and my secretary, Dr. Shobha Gudi, Dr. Sunil Ishwa, everybody, thank you for this joining today evening. With this, I request Dr. Prabha and Dr. Priscilla to go forward. Thank you.
Thank you, sir.
Thank you, Durgada sir, for your constant appreciation and encouragement. We'll start with the sessions. Since Dr. Anurag is taking a little time to join us because of his surgery, we start with the second topic. Arun, you share the slides. The chairperson for the second topic is Dr. Subhash Malya.
Priscilla, I'll chair
Yes,
this.
ma'am.
I'll chair this first session. I may have to go. Is he there, Subhash
Okay,
Malya?
ma'am.
Is he joined?
Okay, ma'am.
No, is Subhash
I'm here, ma'am. I'm here, ma'am.
Subhash sir is
Okay, then carry on. Okay, Subhash. No problem. No one. Let him only. Let him chair. No problem. I'll do the second one then. Yeah.
okay. Dr. Subhash Malya is from Calicut, a senior consultant gynecologist, and has done more than 3,000 complex surgeries. Enthusiastic surgeon and a senior. So over to you, sir.
Thank you very much, Priscilla. Thank you very much, Priscilla. I have great pleasure in welcoming Dr. Yamal Patel. Probably Yamal bhai. Currently, it's afternoon at Nairobi, and really nice to meet you. We have a common thing in Davangere also. You know, we have a lot of common connection. Dr. Biju and many others. Dr. PG Paul and Dr. Biju. Sir, I invite you to give your lecture on the electrosurgical unit, sir, and take forward, sir. It's a pleasure having you always, sir, and looking forward to your talks, sir. Yamal, sir, all yours.
Thank you, Subhash. Thank you, Dr. Prema. It's a great honor to be invited to this presentation and seminar on electrosurgery. Very important topic. I am going to be talking on the advanced energy sources. So with that, let me now share speaking language. Save. Okay, can you see my screen now?
Not yet. Yeah.
Okay. All right. So that's my screen. I hope you can see it all.
Yes, sir, it's visible.
All right. So good evening, everybody, to all the spectators, and thank you again to Dr. Prabha Desai and KSOGA. Yes, I am an alumni of Davangere as well, and I have interacted with many of you in many occasions. I'm going to be talking on the energy use in MIGS and how to make decisions when dealing with this. Greetings from Kenya. I'm in Nairobi and 2:40 p.m. I have no financial disclosures. Now, music and surgical procedures. Options available. In open surgery, we do have pressure, putting stable, cleaning, energy, whereas in laparoscopic surgery, we rely on suturing, clips, and energy. We also know that today's surgeon is spoiled for choice around energy options in lap surgery. And you may be at various levels of training or practicing. You may be a novice, you may be a learner, you may be a practitioner, or you may be an expert. Now, it is important to understand that energy use changes dramatically between trained users and novice untrained users. In what sense? In the first moment of stop activating, individual set how the tissue is held, how much tissue is held, what angle you hold the tissue at, and how much pressure you put at, and in troubleshooting when there is a problem. So this is what changes between an expert and a novice user. So when we go to the next slide, it tells us what differences that would make. That would make differences in the charring, in the tissue plume or the smoke that comes out, in the lateral thermal spread that is created, sticking, the efficient action. Need to understand it. I'm quickly based topic. I want to be very clear about the terminology to be used. Please, electrosurgery is not electrocautery. And I would prefer from now onwards, if we do not use the word cautery, because cautery and then branding it, or that's not what we do. So when we talk of touching some electrocautery, you use an electric energy to heat a module, and then you touch it to the tissue, which is what we don't do. We use electrosurgery or diathermy. Then we need to know about the ESU, electrosurgical unit, the circuits, the waveforms, and the effects. So we said bad terminology is the energy of good thinking by Warren Buffett. So please do not use electrocautery. It is not the same as electrosurgery. The ESU is an equipment that changes low frequency household electricity to high frequency alternating current between 500 kilohertz to 3 megahertz. And it controls the wattage, the voltage, and the duty cycle of the current as well. And the newer generation monitors, or the ESUs, actually can monitor tissue impedance and automatically adjust the power settings. Now we go into the circuits. There are two types of circuits we work with. They are both dipole. They require 2 poles. And they involve a generator, which is the ESU, 2 electrodes, and the patient. So there are 2 types of circuits, a monopolar circuit and a bipolar circuit. It's not monopolar energy and bipolar energy. The energy is the same. It's electrosurgery, electric energy converted to heat energy or thermal energy. So energy, it's not energy. It's monopolar circuit, not monopolar energy. This is the monopolar circuit. You'll be discussing this in another topic about the introductions. I'll not go into the details, but it requires a return dispersive electrode in a monopolar circuit. Whereas the bipolar circuit is having the active and the return electrode within the instrument itself, between the 2 prongs of the instrument. It is definitely not going to require, therefore, a return electrode or a dispersive electrode. So it is definitely much more regularly used by us in gynecological surgery. But it is important to know that it does have a lot of medical legal cases around bipolar use, especially in relation to this thermal energy issue. Now, the next thing is about the waveforms. This is the terminologies. So we've done the circuits, we've done the waveforms. There are 3 waveforms. We have the cut waveform, which is at the end of the left end, which is purely undampened, and it is equal all through, and it is low voltage. Then we have coagulation mode waveform, which is the extreme right end, which is very high on and off, and it is going as high as 6,000 to 9,000 volts. But it only is active for around 4 to 6% of the time, which means it's like a lightning strike on and off. And because of that, blue button is actually a dangerous button because of the high voltage. It's a risky current. And then there is blend in between. There is blend 1, blend 2, blend 3, which reduces the damping. So you would have a 100% cycle. You would have a 4% cycle at the coagulation mode. You would have 25%, 50%, and 75% cycle, and the voltage increases slowly. So that is what the blend is. It's a mix between the 2. So we have the cut waveform. You'll be going through this. I'm not going to this specific discussion, the quad waveform and the blend waveform. And we should know when to use which one, because it is not to be interchangeably used. They are not to be used interchangeably. And definitely, please do not use blue to coagulate and yellow to cut. I think that is a misnomer. The blue button does not mean coagulation effect. It is coagulation waveform. Please make this difference very clear. Next thing, we have the effects. We need different effects. Vaporization effect, which is what we call as cut. We have the desiccation effect, which is what we call as coagulation in regular discussions. We have fulguration, and we have coaptation effects. So let's go into bipolar, traditional bipolar, because I'm supposed to be specifically talking on advanced bipolar and ultrasonic. So traditional bipolar, there were issues with it because of varying application methods. People would apply it for a long time, another one would apply it short, another one would apply it continuous, another one will apply it intermittently. So there is variation. The tissue sticking would be different. The tissue charring was a problem. Tissue smoke and plume was a problem. There was lateral thermal spread. There was increased time for adequate coagulation required. It would be slow. And the hemostasis was actually by proximal thrombus formation. Hence, the security of that clot would be not that high. So there were newer bipolars, also called as vessel sealers, that were created. These use bipolar energy, but they also combine it with mechanical pressure. So the difference between traditional bipolar and newer bipolar is the newer bipolar works with bipolar energy and mechanical pressure. It is high current but low voltage. Low voltage means low risk, and it is continuous energy. It is feedback controlled, which means there is an audible sound that tells you the tissue is ready. So when you press it, after a while, it will give you an alert and say, toot, 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 and that tells you that the tissue is adequately coagulated. That's safe to now cut. There was low thermal spread in the newer bipolars, so that the thermal spread, which was 5 to 8 millimeters in the traditional bipolar, is probably only up to around 1 to 1.5 millimeters in the newer bipolars. It can seal a vessel easily up to 5 to 7 millimeters, which the traditional bipolar would have problems with. And it also has the bipolar and a transaction blade. So it has a blade that cuts when you press the button. And it is automatically pulsatile. So it does not decide how I, Dr. Yamal, or somebody else would use it, because it's automatically pulsatile. Because ideally, bipolar should be used pulsatile. And that's not what everybody does when they use the traditional bipolar. And it causes fusion of the vessel by sealing by the collagen and elastin tissue. Hence, it is a better sealer and a more reliable sealer. These are the newer bipolar methods we have. We have the LigaSure, we have N-Seal, we have the Gyrus plasma kinetic cutter, we have the Power Seal, we have Irby Biclamp, Bicision, among others. These are just a few to name. Now, let's take them just one by one. LigaSure is advanced bipolar. It's a vessel sealer causing fusion. It is feedback control. It has tissue sensing and activity. It is a smart generator that gives you an audible feedback. It can safely coagulate vessels up to 7 millimeters with a temperature of less than 100 degrees. So it's safe, and a very low thermal spread of only 1.5 millimeters. N-Seal, on the other hand, is also a smart electrode-based technology, where the smartness is in the jaws. And it has nanotechnological feedback system. It has less energy, requires less energy and heat. It can also seal up to 7 millimeters and does have a high burst pressure. We'll discuss that as we move on. The Gyrus is also an advanced bipolar using plasma kinetic technology, can seal up to 5 to 7 millimeters with a maximum temperature of 100 degrees with two modes, the PK and the vapor pulse coagulation mode. And it also gives you pulsatile energy And there is no feedback mechanism here, but the lateral thermal spread is around 2.7 millimeters. Now let's go into ultrasonic, for example. Now this is mechanical, vibratory, and not electrosurgery. There is no electrosurgery here. It is mechanical energy. The electricity ends at the transducer entrance. It is high-speed mobilization with cavitation effect. And the active blade is the straight black one in this picture. And the other one with the Teflon tissue pad is actually the inactive blade with 5 power levels. It is versatile with an excellent dissection, good coagulation, cut and grasp method. It gives you a 1 to 4 millimeters lateral thermal spread and seals easily up to 7 millimeters in the newer ultrasonic tissues, but it has a high residual heat. These are all the various ultrasonic types of instruments we have: sonicision, harmonic, the sonic beat, sonosurge, iScalpel, Inolcon, etc. What are the pros of ultrasonic? It is fast. It is very precise dissection, giving very good histological margins. It's versatile. It has a very low lateral thermal spread with a low post-op pain and nausea, less wound seromas, and less smoke. However, it has very high residual temperature. The probe gets very hot, almost above 200 degrees centigrade. So if you have used it and you touch the probe, even without activating it to a bowel loop, it can actually easily burn that bowel loop because it's very hot for the first few seconds. It is usually marketed as a single use, and therefore cost can be an issue unless you have a way of reusing it, maybe by using the ETO. It causes aerosolized fatty droplets and affects vision, and it has a slower coagulation than electrosurgical method. We have Thunderbit as well, which is a combination of ultrasonic and advanced bipolar sealing. So this now brings us to the question, okay, this is a lot to take. How do we decide which one to use? This is how we decide. We decide based on burst pressure, the seal time, the thermal damage that it causes, that is lateral thermal spread, the residual heat, versatility of how you can use it for different functions, the cost, and the histological margins. Let's take them one by one. So this is how they were actually studied on different aspects. When we did the study of burst pressure, this is the pressure at which the vessel, the sealed end of a vessel would leak. So if you have sealed it and then you put pressure and then you're trying to open that seal, how much pressure is required to open the seal is the burst pressure. When they did bipolar burst pressures, bipolar 1, 2, 3, etc., you can see it was around 489 to 680. And ultrasonic gave you a burst pressure of 435 millimeters of mercury, way above our arterial systolic pressures. But when you go to that, it opens up the vessel. Hence, if you look at that, the bipolar vessel sealers and the ultrasonic actually in vessels less than 5 have an equal strength. Let's go to the ones above. When you go above 5 millimeters, the ligature, the PK, the N-seal have these different pressures. You can see ligature had among the best. But when you go to ultrasonic, it was much lower. And hence, in vessels that are above 5 millimeters, we would say ultrasonic was slightly inferior to the bipolar vessel sealers. The newer ultrasonic, like the harmonic A's and the 1100, definitely have a very good or equal burst pressure as well. We go to the next one, thermal damage. How much lateral thermal spread is happening with that instrument following an activation? Well, in the traditional bipolar, it was almost 5 to 8 millimeters, but you can see that it is much lower in the newer bipolar vessel sealers. It's around 3 to 4, and ligature was around 1.5 millimeters. Whereas ultrasonic was very thin. It was only 0.6 to 1.5 millimeters in veins because it's a very thin vessel, but it was not significant, statistically. And hence, we would say that in this one, the ultrasonic had a slight edge over the other bipolar and monopolar or advanced bipolar as well. We go to residual heat. We decide based on how hot the tissue, the probes of the instrument get after the activation. And we had seen that if you then touch a tissue with that end, even without activating it, it can still be very hot when it's ultrasonic as opposed to when it's bipolar. Hence, you have to be extra careful not to touch tissue that is very friable, like the urethra or the bladder or the bowel, with the ultrasonic soon after you have activated it, because it is going to be still very hot. It takes around 5 to 8 seconds to cool down. So this makes the bipolar, advanced bipolar, superior to ultrasonic or the traditional bipolar and monopolar. Now we go to dissection. The ability to help in dissection phase, grasping at the time of instrument activation, and the smoke and plume. Now ultrasonic really helps or facilitates dissection by the cavitation effect, whereas the bipolar sealers are poor graspers and also not very good dissecting tools. Hence, in cases where you need very fine dissection, like when I do my deep endometriosis or bowel endometriosis, then ultrasonic gives me an edge over the vessel sealers and bipolars. Although the bipolar shears can also be used for similar procedures. So in this way, ultrasonic again takes an edge over the traditional bipolar and advanced bipolar in dissection. Finally, cost comparison. Is it single use? Does insurance cover it? Is it available in your country and hospital, etc.? So I would say it was equal in ultrasonic and advanced bipolar, but superior when you have the traditional bipolar or monopolar, because that is a cheaper option to work with. So each of them have their own strengths. Ultrasonic is really, really good in dissection phase, whereas bipolar vessel sealers are very good hemostatically. When we go into the other options of traditional bipolar and monopolar, these are widely used, they are cheap, they are reusable, and they do have obviously a lot of thermal spread, they can stick, they have some charring, etc. Now, ultrasonic, in summary, it's very good as a sealer and cut in one. It has increased dissection speeds with minimal thermal spread, less carbonization and smoke, and it's very versatile because the same instrument can be used to dissect, cut, and coagulate, but it's a poor grasper. It does go very high in temperatures up to 200 degrees, and the tip can remain hot for long, and it can be used less in vessels above 5 millimeters. The advanced bipolars and sealers, they have active feedback. They actually take automatic control of telling you when it is ready. They do have heat control. They don't go above 100 degrees centigrade. They use low voltage and high current, making it safe. They have a very low thermal spread, less carbonization, and can easily go up to vessels up to 7 millimeters. However, poor in dissection and slow in activity. So, Thunderbit combination could be simultaneous seal and cut, minimal thermal spread, continuous bipolar support with the cut, and the advantage of ultrasonic dissection. Does have a decent grasping capability, minimal scarring and charring, single action jaw making it dissection tricky, and the fine tissue handling can be difficult. So the choice finally comes down on the ergonomics of the handle and the instrument, the cost, safety profiles, smoke produced, tissue sticking, whether it is multifunctional or not, effective hemostasis, and in difficult situations, how is its performance? So this is how we would decide on the use of ultrasonic versus advanced bipolar. In conclusion, there is insufficient evidence for any one technology to be superior over the others. Know all the available methods, be very familiar with one type and use it accordingly. The ultimate choice of instrument should be based on anatomic consideration of the surgery and the surgeon's familiarity and preference. And obviously, it's not the wand It's the magician. Thank you very much.
Thank you, Dr. Emin Patel.
Himal bhai, thank you very much. It was a wonderful talk. Actually, I was following a few of the principles, and I was telling my resident, okay,
Yes.
that I was telling my resident, that where what you were said, mechanical pressure with electroconduit, that the seal is formed. So I was actually using a vessel sealer over here, the same thing again. But some of my
Yes.
residents did not follow it up. So I'm actually a bit scolding them. That's the mechanical surgery which actually helps you out with this. So thank you very much for the wonderful and the precise talk. I think it's a very, very dry topic and very difficult to, for people to understand. But you have to understand your basics. You have to understand your surgery. Your electrosurgical unit is very, very important. You have to get to the basics of it. And I think we have followed by Dr. Anurag, who will actually be taking the basics of it. But anyway, Himal bhai, thank you very much. And I'm really, really happy to see you that even you are using the vessel sealer very much. And I'm a very
Yes.
big fan of the vessel sealers. Right?
Thank you.
Thank you. Thank you very much, bhai. Thank you. Thanks a lot.
Thank you, Subhash sir, joining us from the OT. And thank you, Dr. Yamal. We'll take up the questions after the next session. Let's move to our second topic. Dr. Anurag has joined us. He'll be talking to us on principles and physics of electrosurgery in endoscopy. Our chairperson for this session is Dr. Prema Dikuna, my teacher and mentor. Thank you, Prema ma'am, for accepting our invitation.
Thanks
Ma'am
to you,
has been
the best student we can have. An example.
Thank you, ma'am. I owe my practice to you.
This example of what an excellent student you are and you were.
Thank you, ma'am. Ma'am has been the past president of Mangalore Society. She is a teaching faculty over last 35 years and holds special interest in clinical research and teaching. And I must say, the most of people from Mangalore, if they have done their first surgery, it is because of Prema, ma'am. Over to you, ma'am.
Thank you, Priscilla. That was more than. It's so good to hear from my students and what you mean to me. I welcome Dr. Anurag Bhate. Yeah, I don't know you personally, but it's wonderful to meet you here. And I'm sure you must be excellent to be chosen by this, given the honor by Dr. Prabha to speak on this energy devices. So Dr. Anurag is from the director of the maternity, your own or your dad's? Maternity and endoscopy.
My own, madam.
Yeah. Okay. So you're a first
I am the first generation.
First
yes.
generation. Good. No, we never know, but excellent. Congrats
Agreed,
on
madam.
that. Okay. And you're from Mumbai.
Yes, I am situated in Mumbai.
And so you work at Vadia. You are also attached at Vadia and Nanavati and many other hospitals. Welcome, and I will get to know more about you as you give your talk.
Thank you. With all due respects, madam. Thank you for that kind introduction. Thank you, Dr. Prabha, for inviting me for this talk. Dr. Yamal has covered many of the things, but the principles are already. I'll just share my screen first. Is my screen visible?
Yes. But not the slides. It's at Google.
Just a second.
Till he opens his slides, I want to tell about Anurag. Dr. Anurag is my senior colleague from KEM. And
yes, I think
very good academician, and he is very active in IG, and he conducts so many of teaching programs and all. And he has recently inaugurated his one more unit of Bhate's hospital. Congratulations, Anurag, and I hope now you will start the talk.
Thank you. My screen is visible?
Yes, Anurag. It's clearly visible.
Yeah.
Nice.
Yeah. Thank you, madam. So let's first one go to the history of electrosurgery, that is dating back to antiquity. Applying heat to wounds was a part of treatment. So during Neolithic skulls unearthed in France revealed evidence of cauterization. Hippocrates used heat to destroy growths and treat epilepsy. Albucasis in 1980 BC described using hot iron to stop bleeding. Now coming to electrosurgery is often erroneously referred to as electrocautery. Mechanism of action and possible outcomes including potential risks are quite different. Now, one more term, surgical diathermy means thorough heating, not a feature of monopolar techniques, may apply to certain aspects of bipolar electrosurgery. Arsenal D. Arsnoval in 1893 first used high-frequency alternating current for therapy. Cushing and Bowie published their result in 1928, described three distinct effects of electrosurgery, that is desiccation, cutting, and coagulation. In the early 1970s, electrosurgery was the main energy source used with great efficacy during laparoscopy, mainly sterilization and adhesiolysis. Anecdotal reports of bowel injuries secondary to sparking prompted to develop bipolar instrumentation. So by 1980, bipolar electrosurgery had become a standard practice of most of laparoscopic surgeons. And to add to this knowledge, at present also in robotics, there are only two energy sources which are used, which are monopolar and bipolar. So in parallel, a laser instruments became available for endoscopic surgery. Despite the early promise of laser, no study to date has demonstrated a reduction in lap complications, especially bowel injuries. Near the end of 1980s, the general surgeon recognized the advantage of laparoscopic surgery, especially cholecystectomy, and started using the electrosurgical generators. Surgeons are expected to be familiar with the tools and appreciate the variables inherent in each technology. Now, most important is a very little attention is paid to the applied principles of electrical physics during the training program. We or madam or anybody who is now joining this webinar, we should know that during our post-graduation programs, we were very less aware of the electrosurgical units. Most of them we have learned is after post-graduation. We only knew to connect the cautery and use it. Well, by assisting also, we were like touch. We had no idea. We just touched and everything got cauterized. So electrosurgery is mostly considered as a skill to be acquired by hands-on exposure. Many myths about the risk of electrosurgery have been perpetuated. Absence of fundamental knowledge handicaps the potential to transform the science to an art. So modern electrosurgical units is a finely tuned solid-state instrument that offers many versatile variables for the contemporary surgeon to harness to obtain a specific effect and outcome. Let's get to the fundamentals of electrosurgery. What is electrocautery? What is electrosurgery? Direct current and alternating current. Dr. Amal has described uses of these current in various higher modality instruments, but let's get to the basic. So use of direct electric current to heat a metal conductor with a high resistance, which makes the metal physically hot. Tissue is then directly heated or cauterized by touching the hot metal object. It has the disadvantage of having no precise control over thermal effect. We don't use usually now the term electrocautery, we use the term electrosurgery, which involves manipulating electrons through living tissue by using high frequency alternating current through enough current concentrate to create heat within a tissue cell to destroy the tissue. What is direct current and alternating current? Direct current flows in one direction only, whereas alternating current flows to and fro. First increasing to a maximum in one direction and then increasing to a maximum in the other. This sinusoidal waveform can be interpreted or interrupted or varied to get the different surgical effects. This is the main principle on which most of the electrosurgical units work. So electrosurgical surgery is one of the most commonly used energy systems in laparoscopic surgery. The surgical team should have a good understanding of the principles of electrosurgery and tissue effects to avoid complications. The risk of complications is linked to the surgeon's fundamental knowledge of instruments, surgical technique, biophysics, relevant anatomy, and safe technical equipment. Now, what are the principles in which the electrosurgery work? First is watt, that is a power. It is the product of current and voltage. So power is the amount of current times the voltage level at a given point measured in wattage or watts. It corresponds to the rate of work being performed, that is W into V into I. This we have learned in physics, but we never thought where it will be applied. Yes, it is really applied in electrosurgical principle. Ohm's law, everybody must have heard. We have studied in our times, but we don't know how it is applied. Now, when we use our electrosurgical units, we know the Ohm's law, which shows the relationship between the properties of electrosurgical energy. Current is what flows on a wire or conductor like water flowing down a river. Current flows from negative to positive on the surface of a conductor. Current is measured in amperes. Now, voltage is the difference in electrical potential between 2 points in the circuit. It is the push or pressure behind current flow through a circuit and is measured in volts. Resistance determines how much current will flow through a component. Resistors are used to control voltage and current levels. A very high resistance allows a small amount of current to flow. A very low resistance allows a large amount of current to flow, and resistance is measured in ohms. So we have current, which is ampere, volt, wattage, and resistance. Electrocautery refers to a direct current, electrons flowing in one direction, whereas electrosurgery uses alternating currents. Modern day electrosurgery is the utilization of AC at radio frequency levels. During electrocautery, current does not enter the patient's body, only the heated wire comes in contact with the tissue. While in electrosurgery, the patient is included in the circuit and the current enters the patient's body. This you can see a direct current electrocautery. It is a flat line at voltage and time. And alternating current you can see in electrosurgery of the voltage and the time pattern. Now, electrical current flows when electrons from one atom move to adjacent atom through a circuit. Heat is produced when electrons encounter resistance. For current to flow, a continuous circuit is needed. In the operating room, the circuit is composed of the patient, the electrosurgical generator, the active electrode, and the return electrode. So the electrosurgical units is the source of the voltage. Electrical energy is converted to heat in tissue as the tissue resists the flow of current from electrode. Three tissue effects are possible with today's electrosurgical units: cutting, desiccation, and fulguration. Achieving these effects depends on the following factors, that is the current density, time, electrode size, tissue conductivity, and current waveform. What is current density? As expected, the greater the current that passes through an area, the greater effect it will have on the tissue. Time. The length of a time a surgeon uses an active electrode determines the time's effect. Too long an activation will produce wider and deeper tissue damage. Too short an activation will result in absence of desired tissue effect. We have seen even during cesarean, when you hold a vessel or a bleeder with a artery forceps and then you touch your cautery current to it. If it is just for a shorter time, we say to the residents also, touch and go, touch and go, so that the slight amount of current will just only desiccate the minimal tissue. But when we want a more, we just say just keep on touching till it really gets charged. This is what is the time does to the tissue. Electrode size. With respect to electrode size, small electrode provide a higher current density and result in a concentrated heating effect at the site of tissue contact. Following the same, the patient return electrode used in monopolar electrosurgery is large in relation to the active electrode in order to disperse the current returning to the ESU and minimum heat production and this return electrode size. That is why the electrode size we use is smaller and the patient plate is much bigger, because the amount of current it will take out to the body has to be reciprocal, otherwise there will be a leakage of current. Tissue conductivity. Various tissue types have a different electrical resistance, which affects the rate of heating. Adipose tissue and bone have a higher resistance and a poor conductor of electricity, whereas muscle and skin are good conductors and have a low resistance. Current waveforms. The final determinant how tissue responds to electrosurgery is the current type. Electrosurgical units, again, three different waveforms: cut, blend, and coagulation. Dr. Amal has highlighted on all the three types. This is the same chart when you see a pure cut, blend 1, blend 2, blend 3, and blend coag. You see the percentage: 100% in pure cut, 50% in blend 1, 60-40 in blend 2, 25-75 in blend 3, 6% and 94% in coagulation. Now, what I am meaning by it is, a pure cutting, that is a vaporization waveform, is continuous, unmodulated, and undamped. A coagulation waveform is interrupted, modulated, and damped current, while a blend waveform is a modification of cutting waveform and is used when hemostasis is needed while cutting. This waveform consists of combination of both cutting and coagulation waveforms. Higher blend settings translate into more time between bursts of current and greater coagulation, as seen in the following example. In blend 1, sorry, there will be 80% current, 20% coagulation. In blend 2, there will be 60% current, 40% coagulation. And blend 3, there will be 50-50 cut and coag. A cutting current power setting must be between 50 watt and 80 watt to be effective. This is very important. Normally, we don't see how much cutting power setting we are using. Our ESUs are usually set at 40 to 50 watts. 40 is an adequate which is required. 50 is we normally keep if it required. But if you are doing a hysteroscopic myoma resection, everything, we can go up to 100 and 110. Ideally, the electrode is held slightly away from the tissues to create a spark gap or steam envelope through which the current arcs to the tissue. This spark gap results from heating of the atmosphere between the electrode and the tissue. The coagulation current is effective with the power settings of 30 and 50 watts. Again, same. If you ask your technicians, they will usually keep the coag setting at 40 watts. Fulguration, that is a spray, is a non-contact coagulation that also utilizes spark gap to mediate tissue effects, which results in heating and necrosis as well as greater thermal spread. Desiccation, that is a deep, is another form of coagulation in which direct contact is made with the tissue, resulting in electrical energy being converted into heat within the tissue. The end results in deeper necrosis and greater thermal spread. This is a very important chart. If you see, 4 types of currents: monopolar, traditional bipolar, advanced bipolar, and ultrasonic bipolar. So tissue effect is cutting coagulation in monopolar. In traditional bipolar, it is just coagulation. In advanced bipolar, it is cutting coagulation, and in ultrasound, it is cutting coagulation. Power settings: monopolar 50 to 80, bipolar 30 to 50, advanced bipolar are default settings, and ultrasound is 55,000 hertz frequency because it is a sonic current. It's not even a current, it's an ultrasound related device. So thermal spread is not very well assessed in monopolar, but in traditional bipolar, it is 2 to 4 mm, 1 to 2 mm in advanced bipolar, and 1 to 2 mm in ultrasound. What is the maximum temperature in monopolar? It can go above 100, traditional bipolar above 100. Advanced bipolar systems which are presently are used, you cannot really well assess, but in ultrasound is less than 80 degree. Vessel sealing ability is not, it's not in monopolar. Traditional bipolar also, it is not well assessed how much size of vessel it will seal. Advanced bipolar, yes, it is less than 7 millimeter, and ultrasound is less than 5 millimeter. Technique, not monopolar and all is not applicable. Rest is a tension-free applicable. In monopolar electrodes, radio frequency current flows from the generator through the active electrode into the target tissue through the patient, the dispersive electrode, and then returns to the generator. The most common site of injury at a patient is the return electrode. The return electrode must be of low resistance and with large enough surface area to disperse the electrical current without generating heat. If the patient's return electrode is not large enough or is not completely in contact with the patient's skin, then the current exiting the body can have enough density to produce uninhibited burns. Excessive hair, adipose tissue, bony prominences, and the presence of fluid and scar tissue comprise the quality of contact. So we should keep in mind the area should be scar. There should not be very less hair. That is why most of the times either we put it on the back or on the thigh, where a maximum contact area will be there for the return plate. In bipolar electrosurgery, the active and return electrodes are located at the site of surgery, typical within the instrument tip. The classical example is 2 tines of the forceps that are active and return electrodes and present the entire circuit. Most bipolar units use a lower voltage waveform to achieve hemostasis and avoid collateral tissue damage. A bipolar electrosurgery has a more limited area of thermal spread compared to that of monopolar and is similar to that of laser. The maximum thermal spread is within 5 mm and the depth limited to probably serosal layer. Disadvantage of bipolar electrosurgery include increased time needed for coagulation due to low power settings. There might be charring and tissue adherence with incidental tearing of adjacent blood vessels. This we have seen if we are using, when we still use bipolar for uterine coagulations and larger vessels. We keep on desiccating and keep on desiccating, and we see there is an entire charring of the uterine vessels. And when you remove the bipolar, the entire tissue gets adhered to it, and the blood vessel just opens up or tears. So you have to give small bursts, and you can put saline in between to avoid that kind of adherence to the blood vessel. This is monopolar coagulation, where you can see a patient plate and the patient is a part of circuit. While in bipolar coagulation, the patient is not a part of circuit, only the tissue is a part of circuit. Now, what are the safety measures for prevention of electrosurgical complications? First, inspect insulation carefully. Use the lowest possible power setting. Use a low voltage waveform that is cut. Use brief intermittent activation. Do not activate in open circuit. Do not activate in close proximity or direct contact with another instrument. Use bipolar electrosurgery when appropriate. Select all metal cannula system as safest choice and utilize available technology to eliminate whatever the concerns are there. I think most of the newer technologies have covered by Dr. Amal, but I'll just go in short. A vessel sealer, the most recent advances in electrosurgery has been the introduction of vessel sealing. Core to this technology is the use of bipolar electrosurgery that relies on tissue response generation. This advanced electrical current is combined with optimal mechanical pressure delivery by the instruments to fuse vessel walls and create a seal. Specifically, high current and low voltage are delivered to the targeted tissue and denature the collagen and elastin in the vessel wall, while the mechanical pressure where the instrument allows the denatured protein to form a coagulum, that is how it seals. So vessel up to 7 millimeter diameter and large tissue bundles can now be surgically sealed. We use the word ligated, but it is surgically sealed. Additionally, thermal spread appears to be reduced compared to traditional bipolar electrical surgical system. Personally, I don't use vessel sealers because once it seals, then it stops sealing further. And if there is a bleed, then that vessel sealer takes time again to get restarted. So many a times I use a simple bipolar to completely seal the vessel, and then you can cut with a scissor or a shear or whatever. Coming to the ligation system, produces a supraphysiological which seals significantly higher bursting pressures than the plasma kinetic sealer in vessels ranging from 4 to 7 mm. The plasma kinetic seal becomes progressively weaker while the ligation seal increases in strength as the vessel seal increases. The N-seal is another instrument, adjust dose energy simultaneous to various tissue types and tissue bundles, each with its own impedance characteristics. Less heat is required to accomplish fusion as the tissue volume is minimized through compression. Energy is focused on the captured segment in the vessel walls are fused through compression, protein denaturation, and then renaturation. Harmonic or ultrasound technology is an surgical instrument cutting and coagulating tissue operating at a frequency of 55,500 cycles per second. There is no electrosurgical current generation. The combination of mechanical energy and the heat that is generated is causing protein degeneration, formation of a coagulum that seals small blood vessels. Typically, this energy modality is effective for blood vessels between 2 millimeter and 3 millimeter, although a newer device is demonstrating ability to coagulate vessels up to 5 millimeter in diameter with less heat, charring, and thermal injury to the surrounding tissue. But if during bowel dissection, this is very, very useful because the thermal spread is very minimal. You can see the working pattern of ultrasound. Electric energy from the generator is converted to mechanical energy at the handpiece. Now, the two cutting mechanism of harmonic spiral are different from that observed with electrosurgical laser. The first mechanism is cavitation, cutting, and fragmentation. As the blade tip vibrates, it produces large transient pressure changes which causes cellular water to vaporize at low temperature, rupturing cells, leading to very precise cutting and dissection. The second mechanism for cutting by harmonic scalpel is the actual power cutting offered by a relatively large blade, which is vibrating at 55,500 times per second. The blade edge cuts tissue by stretching it beyond its elastic limit and on more macroscopic level by breaking molecular bonds. So it is most important to understand how it cuts the tissue or coagulates the tissue. The heat generated from friction of tissue is typically less than 80 degrees centigrade. This minimizes tissue charring, desiccation, and zone of thermal injury. Disadvantage of this technology are the formation of aerosolized fat droplets from the tissue being treated, which can interfere with visualization through a laparoscope. But it's very minimal. The latest one is laparoscopic coagulating shearers. This device allows unsupported tissue to be grasped and coagulated without difficulty or it can cut and coagulate like pair of scissors. Now coming with the advent of new technology, it is crucial to understand the mechanics of how instruments work to fully be able to utilize them and prevent injury. The ligature has the highest burst pressure and fastest sealing time and was the highest rated overall. The harmonic scalpel produced the lowest thermal spread and smoke but had the lowest mean burst pressure. The Gyrus plasma kinetic had the highest smoke production and variable burst pressures. Despite using nanotechnology, the N-seal device was the slowest and variable burst pressures. These were all other issues with these instruments. Conclusion, principles of electrosurgery must be thoroughly understood by all operating room personnel. This forms the basis for patient safety and helps in early recognition of possible complications. The advantages and disadvantages of various forms of electrosurgery must be borne in mind while using a particular modality. Newer technologies with more efficient hemostatic properties must be used whenever appropriate. Thank you. Thank you, everybody, for your patient hearing.
Thank you, Dr. Anurag. It was wonderful talk, and it is as you said, most of us we start using it, but we were not aware about its exactly how it works and what are the technical hitches of using it all. And do you want to tell about the little bit about shearer, which is an Indian invention?
Yeah, this is a very good Indian invention which we are using. It has both coag and cutting qualities, but it has a learning curve. Again, coming back to shearer, there are two blades. One is a blunt blade and one is a sharp blade. But the blade doesn't move. It is
Yeah.
basically the current which is converted into a mechanical energy, and there is vacuolization of the cells, and then it bursts and then it coagulates. But with me, for uterines, I personally I don't only use Shearer, but I use a combination of bipolar and Shearer. Shearer is a very good coagulator and cutter, but for larger vessels, it might have its limitations where you have to use a regular bipolar.
Yeah, as you said, right? Usually, while taking by this thing, uterines and all, we always use regular bipolar, and while cutting, you can use shearer if you want.
So whosoever, if any residents are there or who are going to learn,
Postgraduate.
yes, postgraduates who want to learn into endoscopy or go into endoscopy, a simple bipolar should be always in your armamentarium. That is a basic instrument. You can use harmonic, you can use INSEAD, you can use ligashure, everything, but you should always keep a bipolar because every instrument has a learning curve. It's not that day one I start using harmonic, I'll be tuck, 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 and I can finish. No, it never happens like that. Every instrument has a learning curve. There is a machine, a man is always there behind the machine. But you have to, same is with the shearer. It's a very new instrument. It is getting upgraded daily. Somebody is making some changes in it. Either the blades are increasing, distance are increasing, the current dissipation is changing. So you have to see which instrument you are using, how much time it takes to cut and coagulate. Because at the end of the day, whenever there is a thermal spread, the consequences are really damaging.
Dr. Anurag, that was, yeah, you want to
Yes,
say
madam.
something, Dr. Prabha?
No, ma'am, you can.
So what would be the ideal current setting to while using a vessel sealer or and a shearer?
Both 40 is, see, I keep it at 35 watts.
For
Basic
both when you're using both.
both 35 watt. The problem with vessel sealer is once it seals, you can see Dr. Amal said it will be tuck, 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 and it will stop sealing. Once it recognizes it has sealed the vessel. But many a times, if the vessel size, see, when patient has severe menorrhagia or she has large fibroids, the uterine will not be 5 mm. It might be 7 mm, it might be 8 mm. You can see huge bulky uterine bundles when you do big uteruses, large fibroids, some mucous fibroids. At that time, many a times the vessel sealer doesn't seal completely and it starts oozing. And when that area starts oozing, people start panicking and start coagulating and desiccating here, there. That's where injuries happen. So first and foremost thing, once, so my both settings are 35. 40, 45, you go about the thermal spread is much higher. But at 35, if you use your bipolar very nicely, it automatically, it seals everything. Then you can even cut with a vessel sealer. There are instruments which you can cut with that also. Sorry, my battery is low.
Okay, okay. I thought you were going to show something there.
No.
So what is the shearer that you are using?
Spot, yeah, like, that's the
So
good.
which shearer are you using routinely?
There is this guy who makes for me. I have told him to this, his company is a local surgical company. One day he came to me and he showed his shearer. Sorry, sir, I just connect. Yeah. So he came to me and he showed a shearer and he said, one of my colleague is using. Now I'll tell you a very good story about shearer, madam. So then I said, I formulated it according to myself and I started using it. I was very happy using it. Then one day the same guy came to me and told me, I have made a new shearer. The blades are little longer. I said, okay, I'll use and see. The first hysterectomy, it was cutting very nicely. The first hysterectomy which I was doing, I realized I am cutting very closer to the tissue which I don't want to. And suddenly I saw I was maybe a 2-3 millimeter just close to bladder, which usually when you operate, you know. So that's when I called him up and asked, why you have elongated the blade? He said, oh, और काटता है मतलब हमको और काटना नहीं चाहिए हमको जितना
Yeah.
जितना काट रहा था वो अच्छा था. So the people who make, they don't know. They just keep no, somebody tells कि इसको sharp कर दो, इसको you make it like this. No, so you sit with him, you can make a कि I need this blade this much long, but for that you have to use it for that much time. So this local vendor makes for me and I am using it since last 2-3 years. I am very happy with it.
This was an excellent talk, Dr. Anurag. Yeah, it is like it may be like dry, but it was very important. And by you explained how the machine works, how it is important for us medically how and surgically, and how we can minimize problems with it, and what are the best tips you gave us so that we can use it well. Thing. I
Thank you,
had a
ma'am. Thank
question
you.
about the smoke that occurs.
Yes.
Yes, yeah. Uh, I think that's an important, and I don't seem to see it addressed anywhere as such. It's either for you and yeah, the other first
No,
speaker, Dr.
yes.
Patel, do. Yeah, we
Most of
evacuated it
the
to the OT. It's all onto us, right?
Yeah, so what we do normally, there are this smoke evacuators, smoke reduction devices available, which we started using in COVID times. Now you can attach those, and the smoke goes out. But to reduce the smoke, you don't have to desiccate the tissue till it chars.
Yeah.
So you give small bursts and multiple points so that the tissue gets desiccated, and then you cut in between. It will still produce some amount of smoke. Harmonic is which doesn't produce any smoke. Rest all of them produce smoke. With ligature also it is there, NSIL also there, sharer also is there, bipolar also is there. So nowadays what we do, we attach 100 mm IV set which we use for patients, and we let it go down in a bucket or in a water so that the
It will
CO2
rise, right? Smoke is supposed. You
no,
put it
but let
in
it
the
be.
water.
At least it is not directly coming to us. That's what is the.
Yeah.
But if you use small bursts, then the smoke really becomes less.
Yeah. Another other point I wanted to tell the audience is learning physics. One would think just by habit we are using it, and that's enough for us. We can learn it on the job, but we haven't found the ideal energy vessel sealer yet. So knowing the physics behind this, maybe we can get all these points which were you found useful in one, and then the second one, third one, we can put them all together and do. So that's the importance of learning from basics. We can build up. So, and an example you gave, lumber holding longer the shear blade didn't make it better about it. It
I'll
has
put it. I'll put it in a very simple way. One of my students asked me this, and I explained to him, when you make a dosa, the tawa size can be different for anybody else. It can be small, large, big, everything. But if you let the dosa there for 5 minutes, it's going to be burning. It doesn't
it's
depend upon
all
the size of tawa.
yes,
So the importance is how much time your tissue is exposed to that energy is important.
yeah, the thing it was. And again, this topic is important, like you explained. I want to just bring home, it's important for patient safety, you said, and ours. If patient is
Yes.
safe, we are also safe. So
Yes, madam.
important that we know these things. We're using it so often, even if it's for open surgery or for endoscopy, but we need to know this, so that because we have to be on top of things, and like you said, not just by some knobs to be turned there. It was. Thank you. If there are Priscilla, if there are any questions for the for this both the speakers.
Madam, we are taking the questions little
Question later.
late.
Okay,
Yeah,
okay. That's
ma'am.
fine. So we're
Because
done with this. Please, we can move to the next
sure,
topic.
ma'am.
Thank you,
Thank
Dr.
you so
Prabha.
much.
Thank you,
Thank
madam.
you,
Thank
thank you,
you.
Anurag.
Thank you. Bye. Thank you.
Thank you, Dr. Anurag, and thank you, Prema ma'am.
Yeah.
We move to the third
Prabha, am I
topic.
audible? Am I audible, Prabha?
Yes, ma'am.
Yes,
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 Yes, ma'am.
Shobha
Yes, ma'am.
madam.
Yeah.
yes,
So I
ma'am.
must congratulate you and the speakers. Lovely talk by Dr. Anurag and
Yes,
the
thank
previous
you,
speaker
ma'am.
also. And yeah, I will take your leave now because I have to log in.
Madam, thank you, madam. Thank you for joining and giving so much time for our
Yeah,
webinar.
it was lovely
And
actually. Lot to learn.
yes,
Very
ma'am.
basic topic in laparoscopy, but a lot to learn. Hi, Sunil. Good to
Yeah,
see you.
ma'am.
Kasoga.
Yeah.
Hi.
Good to
Hi.
see you. Thank you. Thanks.
Dr. Anurag, that was a very practical talk, and we look forward to having you again in Kasoga. Yes.
Thank you, madam. Thank
Thank
you.
you, madam.
It was a
Thank
pleasure to see you, madam. Thank you.
Yes, yes, thank you.
Thank you, Shobha ma'am, for joining us.
Yeah, Priscilla. Thanks a lot for
Thank you,
inviting me.
ma'am.
All the very best, huh? बहुत अच्छा. Very, very good. You're doing very good.
Yes,
Okay.
thank you, ma'am. Thank you.
As good as your surgeries, you are doing the committee work.
It's
Excellent.
all your blessings, ma'am.
Very good.
Yes.
So, yeah. Thank
Yeah.
you.
Thank you, ma'am. Thank you.
Thank you, ma'am. Moving forward to the third topic, it is by Ms. Bhanupriya. She will be talking to us on troubleshooting and maintenance of electrosurgical equipment. Ms. Bhanupriya is the project manager of J&J.
No, welcome our chairperson, no, Dr. Priscilla.
Yes, ma'am. The chairperson for the last session is Dr. Sunil Ishwar. Arun, can you share the slide? Dr. Sunil Ishwar is a member of BSOG, a renowned laparoscopic surgeon and a fertility specialist. He's passed
Thank you,
his
ma'am.
studies from JIPMER and currently practicing in Bangalore. Thank you, Sunil sir, for accepting our invitation. Over to you, sir.
Priscilla, share the next slide, I think.
Yeah. Arun,
Thank you,
Yeah.
Priscilla, and I would congratulate Dr. Prabha for taking such an initiative. This is really good. When we are involving the industry people, basically they are the ones who take in the, our feedbacks and get back to us with newer devices. I would hope Miss Bhanupriya would share lots of insight regarding the management and troubleshooting of the electrosurgical unit, which actually forms the heart of all surgery. We are like, as we have been discussing so many devices like vessel sealer or shearer and harmonic. Everyone has their own preferences, but one thing is for sure that every unit needs a certain amount of maintenance. So over to you, Dr. Bhanupriya. Hope to hear lots from you. Thank you.
Thank you so much, Dr. Sunil. And I'll firstly thank Dr. Prabha for giving me this opportunity to be a part of this a group of esteemed members. This is my first talk with a group of surgeons, really experienced people. I myself is not so experienced. I've been only 2 years in J&J as of now, only 1 year in marketing. But I think happy to connect with you all. And I think before I start, something which I've observed over the years is that surgeons are usually more focused on the end effectors, which are the probes, monopolar, bipolar. The impact surgeons have in understanding a capital device is very limited. That is where surgeons usually depend on their OT staff, the OT technicians, OT nurses. That is where I feel that the knowledge of a surgeon with respect to a capital device, a generator in the OR is very limited. And that is where I think we usually talk about the devices, the end effectors, but we should also talk a little bit about the generator, because when a generator breaks down in the OR, that is where a surgeon becomes more or less clueless as to what do they do next. That is where they call a nurses or the OT technician to come and help and assist them. So I think not much from my end, but I'll just quickly share my slides and take you through some of the basic material that we have prepared in terms of what are those basic electrosurgical units in your device and the devices that you have in your OR, and what are the basic care and maintenance protocols that everyone should maintain. So if you look at an electrosurgical unit, I have in front of you the MEGen 1. You can have a different electrosurgical unit in your OR. Powers, monopolar, bipolar, cut and coag modes. But the idea in terms of electrosurgical devices, it is providing electrical energy to the patient. Difference between an electrosurgical unit and an ultrasonic unit is electrosurgical unit has current. That current passes through the electrodes, through the pencil or the bipolar into the patient's body. Now you feel, now you see that a patient has current flowing inside the body. So the patient, why does the patient not feel a shock, or why does the patient does not get a burn in the body? That is because the circuit is completed and you have a sticky pad which is sucking away all the current which you have transferred into the body back to the generator. So one of the basics of using an electrosurgical unit is that you should make sure that your sticky pads or a return electrode is always there. A sticky pad, a basic problem which most of the hospitals follow, a lot of OT technicians do it, as that they reuse the sticky pads as well. They reuse the sticky pads for more than two times within a surgery. What does this lead into is that the stickiness of the pad reduces with the number of usages you have with the same pad. Less the stickiness of the pad, less area of contact the pad will have with the surface of the patient. Less area of contact means the pad is not able to suck away all the current which is there in the patient. What does that result into? the current getting accumulated within the tissue getting hotter and hotter. A lot of the surgeons do not realize that during the OR because they're busy in the surgery. And by the end of the surgery, what do you see? A lot of burns happening on the patient body. Very, very important is that when you're using an electrosurgical unit, because there is current flowing through the body of the patient, the sticky pad should not be used more than twice. And if you're reusing the sticky pad, make sure that it is fully covered by maybe a gauze piece or any piece of clothing that you can cover it with, so that it is covering the entire portion of the patient body. I think cut, coag, and blend is something that you already know, so I will not focus my time and attention on this. But I think very, very important to know that since there is current passing through the patient body, electrosurgical units needs to be calibrated, and there needs to be a preventive maintenance happening on all electrosurgical units present in your OR at least once every quarter. Now, this is not a responsibility of a surgeon, but it is a responsibility of the biomedical engineers in your hospitals and the OT technicians in your hospital to make sure that within 3 months, once 3 months, your electrosurgical unit must be taken care of by a company designed field service engineer who comes there, calibrates the devices, makes sure that the output level of the device is as per the commitment. So we have a term called as the output level, which is the power efficiency ratio of a equipment. For example, the input power is 100, but the output power is only 50, which means your current, which is flowing in the patient body, is only 50% of what you have actually added in the electrosurgical unit, which means that your generator is only working at 50% efficiency. That is something that you do not want, which is where preventive maintenance and calibration of the devices is very important. I'll quickly move to an advanced surgical generator, a harmonic generator. You must all be very much aware of it. In terms of in servicing, so I will not talk about the probes, but I think in servicing of this generator is that you should know your generator in and out. You have a power button, you have a connecting device which connects to the connector. Now, this connector, a lot of people do not know it, but it connects both a harmonic as well as an advanced bipolar probe into it. So an N seal or a harmonic, both will get attached to the generator. At the back side of the generator, not just with the Gen 11, but with other generators as well, there is always a potential equalization terminal. Now, this is very difficult. Some of you might not understand it, but I think basics is that whenever there's a software upgrade for a generator, it happens through this port, which is a potential equalization terminal. Nowadays, a lot of electrosurgical units and a lot of ultrasonic generators come with a software. Very common in FT10s, very common in harmonic devices. So when a field service engineer comes to your OR for a calibration or preventive maintenance of the device, that is where he can input a USB device inside the potential equalization terminal and make sure that your device is upgraded to the latest software. What is the benefit of the latest software? The benefit is the newer probes, the newer end effectors which are coming in the market are only compatible with the latest software upgrade. So you make sure that you inform and give adequate knowledge to your OT technicians as well, that your generators must be upgraded to the latest technology software. I think what is very, very important is that a lot of end effectors are attached to a thing called as the handpiece or a gray color cable that you might be having. A lot of feedback that we have received from the field is that surgeons say that the cable is to be reused for 95 or 100 uses, but in between the cable has stopped working. It was only 50 uses and now the cable is not working. So I think the software or the machine has inbuilt settings where if you click on settings, you can go to a tab called as handpiece test. A lot of testing protocols the system already has. Click on handpiece testing and you can test whether your handpiece has remaining uses left or not. Is your handpiece working adequately or not? So a lot of people, they throw something called as a test tip. Whenever you get a handpiece, it comes with test tips. Now, what is the benefit of a test tip? Whenever you're testing your handpiece, you put a test tip in front of the tip of the handpiece, you click on handpiece test, and the system will automatically test your handpiece. It will give you a feedback of number of users remaining with the handpiece. It will tell you about phase margin and impedance. Now, what is phase margin? What is impedance? So if you look at ultrasonic generators, the frequency at which the generators operate is 55,000 hertz, right? So phase margin should always be greater than 150 hertz. So for example, your handpiece has a phase margin less than 150 hertz. It means that it is unable to provide a frequency of 55,000 hertz. That is number one. Number two is impedance. Impedance means the resistance in the handpiece itself. For example, if your handpiece is stiff, it has more resistance in itself, it will be unable to provide equal amount of power which was coming from the generator to the probe. So your handpiece itself has so much resistance that it will stop, or it will suck away majority of the current and will prevent the majority of the current to flow in the end effector. So that is a system inbuilt process. The system will check your handpiece for itself, and still if you feel that the handpiece is not working, please call on a J&J sales representative or a field service engineer. Handpiece cleaning, very, very important, because handpieces are reusable devices. Now, something called as an ETO is very much prevalent. Probes as well as the handpieces are cleaned with ETO. But I think very important is, if you look at a handpiece in depth, you'll find that handpieces have two golden rings inside of them, both the open handpiece as well as the laparoscopic handpiece. And once in a while, it is recommended that with a cotton swab dipped in alcohol, both these golden rings need to be cleaned adequately. It's the dust and the tissue residual materials which pile up on these golden rings, which will prevent the flow of current from the generator to your probes. And handpieces are very, very important. What does the handpiece do? It converts all the electrical energy which is coming from the generator into mechanical energy and throws that mechanical energy into the harmonic end effector or the harmonic probe. So if your handpiece is not working well, your probe will also have problems in working. And I think preventive maintenance, I've been harping on preventive maintenance, calibration, presence of field service engineers a lot. So we have something called as a periodic functional check report or a periodic functional test. So all of the field service engineer or the sales team, if they come quarterly for a check, they must come with a report, and you must also see if they're coming, are they clicking on the basic parameters which they are required to check the device? Are they checking the external components of the device? Are they opening the device? Are they checking the internal components of the device? Are they checking the output of the device or not? So make sure next time if you encounter a field service engineer coming and checking your devices, they carry a functional check report. They're checking the report. You can also cross check that and make sure they're going back with a proper report in their hand. And lastly, I think majority of your time and effort goes in resolving errors. Even we have observed that over the years, the error rates in the machines have significantly increased. Now, this could also be the fact that in India, we also reuse devices. And the way these devices were manufactured, they were not manufactured with the intent of reusing them. But since in India we reuse devices, the probability of errors popping up in the generator also significantly increases. So we have low priority alarms and we also have medium priority alarms. Some of the common alarms that you'll see is reactivate error, or both the foot switches and the hand switches working simultaneously. So it will pop up an error of reactivation. But I think very, very important for all of you is to understand the error before even calling a sales rep that the machine has stopped down. So a common feedback that we receive is that the OT technicians call us and they tell us that the machine has stopped working, but they don't actually tell us what is the error getting displayed in the machine. So for example, if you look at the first error, it says reactivate, and it also gives a description to you. What is the reason for that error? Now, if you look at it, it writes two switch activations detected. That means your hand switch as well as your foot switch, both were activated at the same time. So you might have pressed the foot switch and might have pressed the hand switch both together. That could be the reason why the error has populated. Or it could be that sometimes the foot switches, they're not so cleaned. So inadvertently, foot switches are always in a press on position. They're already pressed on because the screws are not working well in the foot switches, and multiple reasons. Foot switches are always on. And then you also have a hand activation on, and that's why the error might get populated. Now, what is an easy, quick solution to this problem is you go back to your settings and you only select single activation, which is hand switch, and remove foot switches. A basic way of solving the errors. But I think the only way that you can get to this solution is that understanding the error properly. So I will not go to each and every error, and I can, Dr. Prabha, I can share this slide deck with you later on, so you can help your OT technicians understand the reasons behind the errors. But few of the errors I will really feel that it's important for all of you to understand is generator overheating. A lot of the times, OT technicians, they cover the generators with a cloth. That is not recommended, because you see a generator is kept in an on position for more than 5 hours, more than 6 hours. It is running for more than 6 hours, and when it is running, it is producing energy inside it. It's producing energy inside it, it's getting heated up. That is why they have air vents or fans fixated at the back side of the machine. And if you're covering the back side of the machine with a cloth, there is no possible area which the machine has for the air to be thrown out. And when the air is not thrown out, it's getting accumulated in that generator as well, which is making the generator hot, and the generator will populate a message that it is getting overheated. Quick fix to that solution is remove the cover, make sure that the generator is not turned on for a while, and then you can turn it on. So these are just quick fixes. No uses remaining. Now, if the error says no uses remaining, I would suggest go back, check your handpiece, test your handpiece. The handpiece testing will tell you the number of uses remaining. And if it says that there's 0 uses remaining, that's a quick fix to your solution. You need to replace the handpieces. But I think broadly, the reason for majority of the errors is also on the cleaning protocols of your end effectors. We regularly do a program, and I believe a lot of other companies might also be doing, which is called as in-service protocol program for all the OR nurses and all the OT technicians. And we recommend doing this every quarter. So for all the surgeons present here, if you have J&J sales representatives coming to your hospitals regularly, make sure that they do an ISP program in your hospital once a quarter, because it is not a problem of the generator or the device, but I think it's more about managing, because these are not easy devices. And with practice and with practical knowledge is when the OT technicians and the nurses, they get a quick understanding of what the product is. And I think I'll quickly just end up the session with something called as warranty. Now, warranty and extended warranty is something which majority of the hospitals do not take when they're purchasing a generator. And a lot of feedback that we have received is that the generator has broken down. Now we do not know what to do. So I think it's very, very important to sensitize your biomedical engineers that whenever they purchase a device, it is absolutely recommended to purchase a comprehensive maintenance contract as well. The price of the contract is very, very minimal, less than 5% of the cost of the machine. But the benefits are manifold. If your machine breaks down, it is the company's responsibility to replace the machine, to replace the broken part of the machine, repair the machine, and send it back to you. And during that time, we also provide a standby machine. And this protocol is common across all companies. But I think it is not the OT technicians and it's not the biomedicals who suffer. It's the surgeons at the end of the day who gets the majority of the hit because of a machine breaking down, because their surgeries stop. So I think just a recommendation is that sensitize your biomedical engineers as much as you can on the importance of comprehensive maintenance contracts and why it is important and why they need to block budgets right at the start of the purchase cycle so that they don't face the problem of not covering the machine under a CMC over the period of time. I think so. That's all from my end. Thanks, Dr. Prabha. And if there are any questions, I'm happy to answer those.
Yeah, see, Bhanupriya, whether any electrosurgical units functioning will affect as per the earthing of the hospital, or they are independent of that.
So earthing, I think Suraj, I also have ma'am Suraj with me, who's the technical engineer who actually works at the J&J service center. So Suraj, actually, he had something to add on that. Suraj, can you add something on the earthing part of the electrosurgical?
And one more thing is whether should we keep, our electrosurgical unit along with our other, lab trolley, or we should keep it separate, and how much distance we should maintain between this electromagnetic unit and our electrosurgical unit, because that will cause the functioning of this thing, I think.
Yes.
We also don't have an exact idea about that. So better you highlight those few
Yes.
points.
Yeah, Suraj, you want to add before I add
Yes,
my
yes.
comments?
Thanks, Bhanupriya and Dr. Prabha for giving me the opportunity to explain this. The grounding is the most important part for the electrosurgical generators, where or all the other electrical equipments. The grounding perfects the electrical circuit complete. Okay, so when there is any disturbance, there is obvious chances of misleading to the current and voltages, and that may occur the unusual feedback from the generators. So I think I recommend to good to have grounding. That is mostly if your biomedical check with the multimeter, so it should be not bigger than 0.5 volt. So that's my recommendation for a grounding. And for electromagnetic interference, as you say that as our cautery machine is generate or working as a electromagnetic generate a electromagnetic current. So it's actually the magnetic waveform which interference, or is you can say is a radio waveform. So when two waveforms are interference in between, so it's occur unusual feedback that is maybe damage the internal circuit of the generators or the cautery machines. So we recommend that you should have to be place two electro magnetic or radio frequency generators at least 3 feet away from each other.
Yep.
Okay, and can we keep all the like light source, camera, cautery, these all thing in a single trolley, or you recommend the cautery means
Yeah, that
other
all.
electrosurgical unit
Yeah,
than the your
only you should have
electromagnet?
to be taking care of the radio frequency generators. Okay, so you should have to be keep away that required radio frequency generators away from 3 feet away. Other electrical instrument will be okay. That camera and other that.
Yeah, and electrosurgical unit can be plugged in the same this thing with where we are plugging to the cart, where we
Yeah,
plug everything, like light source, camera, then our
yeah,
monitor,
that
everything
will
we
be the
plug there.
okay.
So there can we plug our electromagnetic or electrosurgical unit.
Yeah, that will be the okay. But you should have to be check the capacity of that cart, that
Okay.
handling capacity of the electrical current. If the all they can able to handle the handle the voltages and the current for all instrument present in the
Because
cart,
usually
that
all
should be okay.
electrosurgical units require more of the current than those other camera system and all. So better we should
Yes.
have a other switch, separate switch for
Yeah,
this.
yeah, that will be the recommended. But if some of the hospital are not able to do that, so that will also recommended that that cart have a flexible or a capable capacity to handle that current.
Okay.
Yeah.
Okay. Thank you.
Ideally, Prabha,
Can we take up the
actually,
question on, sir,
After
can we speak up on the ideal way of sterilizing the cables?
Manupriya, please.
Yes, Bhanupriya, you can tell that. Yeah.
Yeah, so the basic protocol is usually in India is that ETO is something that we generally use. But before even getting into the sterilization of the devices, whenever you've used a device, we always recommend that you first of all clean the tip of the device properly. Why do we say that? Is because it's the tip of the device which is used in the dissection capabilities. And most of the time, when you're dissecting a tissue with the tip of the device, the tissue gets clogged inside the tip. And over the period of time, the tissue hardens because it's already a dead tissue. And that hardened tissue, and if you look at the blade design, the blade moves in a to and fro fashion. That hardened tissue will not allow the blade to move in a to and fro fashion where the machine will give you an error that replace instrument or the blade is not working. So it is always recommended that you use a syringe, a high pressure syringe, to clean the jaws of the device. Go inside the jaws of the device, clean it with a high pressure syringe. Once the device is cleaned with fresh water, then you can get into the ETO. That is just for the probe part of it. And if I talk about the cable or the hand pieces, once in a while, it is recommended that the tip of the handpiece, along with the golden rings, they are cleaned with alcohol. With
And
70% alcohol, you can clean them.
and then rest of the cable, and along with that, you have to do ETO every time.
Yes, ETO is recommended, ma'am, because it's a reusable device. ETO is recommended.
It
Okay,
is, yeah.
thank you, Bhanu.
And another thing, when you're using syringe, use syringe, don't attach a needle to it, because many people do that,
Yes.
take a needle and tweak the, tip
Yeah,
of
yeah.
the thing. It's gonna break the insulation and things like that and make the, instrument work badly,
So
right?
needle also results in a hairline fracture on the
Correct.
on the device blade, which a lot of you might not know. But what happens is that the machine is very sensitive. Machine will detect that there's something wrong in the blade.
Correct.
If you look at the probe, you'll feel like, okay, the probe is working wonderfully. It's looking wonderful, but it's just not working. There's some issue with the machine.
Yeah,
Right, Bhanupriya.
thank you,
So it's a
Bhanupriya.
nicely put, Bhanupriya, because as this panel we are using high-end instrument and also the the regular bipolars and all. The more the instrument gets advanced, the more we get stuck. But what happens actually is whenever there is an installation of an equipment happens, we ask the OT technicians or the OT brothers to have a look at it and monitor it. None of the doctors take an interest to go and stand and see what it is. Ideally, it should be a regular training program to see this, because these are high investment also. You can't afford to have a breakdown of this machine and say, okay, we can replace it. So the training is a very, very important part of it. Next is, as you said, whenever there is a breakdown or whenever you are in a fix, you can call the technician, like Bhanupriya said, call the JJ technicians. You can have a video call. Now, that's another brilliant thing, because of internet which has happened, and we have used this many a time, where we make a video call before we pull out all the plugs and say, okay, let's remove this, let's remove that, and see. So have a video call and say, this is what is happening. And it is just a quick fix. They are very quick to react, and they're very good in helping you out, rather than, because every instrument has a number of usage. The more you put it off and take it on, the usage is going. Until unless it is some other person paying for it, it is still okay. But if it is your own, then I think it's rather you have the more thing. And covering with the cloth is like our zamana. When Onida TV or a Dynora came, we covered, and from that time we covered. Even for a normal, bipolar, I've seen people making a plastic cover or the furniture cover thing. That's a wrong thing, because everything has a motor, or everything has a cooling device inside. If you cover it up, it's gonna heat and break the circuits. Ideally, for any electrosurgical unit, we have most complications actually happening because of electrosurgical malfunction. And I we have made a practice in our institute where I'm going is to create a checklist. So the nurse it takes the checklist on all the instrument, but particularly on the electrosurgical units to check the patient's plate, to check the cables, to check the insulation of the instrument, to make sure that we don't start on the wrong foot. So that's another practice every surgeon should imply on their OT technicians, that they create a checklist and follow that, and everything is tick marked before we start the procedure. Thank you, Manupriya, for all that
Another thing, I think
information.
I'm
Thank
not
you.
sure, sir, if this will benefit you all, but a lot of OT technicians, I've seen what they do is a practice of removing the tissue inside the jaws. They use a needle
Yeah,
sometimes.
that should not be
So
done.
that should not be a practice. Instead, if they're finding it hard to remove, they can dip the jaws in hydrogen peroxide for
Perfect.
5 minutes. That will loosen out the tissue, remove it, and then they can do a quick wash.
Exactly.
Yep. Thank you,
Thank
sir.
you, ma'am. Over to you, Priscilla. Thank you.
Yeah, thank you, sir. Thank you, Sunil sir and Bhanupriya.
Thank you,
Yeah,
ma'am.
I think Priscilla will take further.
Yeah, next, moving on, we have the online quiz by Dr. Rashmi Patil. Dr. Rashmi, are you there?
Yes, ma'am, I'm there. Good evening, everyone. And thank you for the opportunity for conducting a quiz in this very prestigious session. So what we will be doing is currently posting a link also. I would request Martin to post the link in the chat box. And a QR code will be displayed and with the timer. So there are 10 questions that you need to log in, and request everybody to attempt them. The one who gets the maximum marks, and if many of them are getting similar marks, then the one who has submitted early will be the winner of the quiz, and they'll be getting a certificate of appreciation from our side. Can you post the link as well, Martin? Yes, thank you. So the link is in the chat box, as well as you can scan the QR code. And in the meanwhile, if anybody has any questions that they want to ask, they can go ahead and interact.
Yeah, now the forum is open for all the three speakers' questions. Anybody has questions, they can ask. Please unmute yourselves or write a question in the chat box, and then you do the.
Okay, I think everybody is busy doing the quiz, madam.
Yeah.
Do you have any question, ma'am, to the speakers?
See, it is in mobile, it is easy to do, right?
Yes, ma'am.
And this thing, no committee members will get prize. It is for other members. We are. You all solve it just for our knowledge assessment.
Yes.
Knowing Rashmi, she has made all difficult questions.
Yeah, no.
Thank you, sir. Ella easy thank you, sir.
Yeah, see, really, anybody is asking. See, Bhanupriya, hello. See, whether there is any life, this thing, what is the life of generator?
So, ma'am, a life of any generator, you pick up
Yeah.
any generator in the market, the serviceable life is always 10 years.
Okay.
So after 10 years, it's always recommended that you change your generator, but it depends from hospital to hospital. The conditions in which they're maintaining the generator also depends on the OR temperature and the humidity of that area.
Okay.
It's always recommended that humidity levels should be minimal wherever you've kept a generator.
Okay.
Yeah.
So the same thing means, see, OT environment will also help, will affect the generator life, right?
Yes.
Okay. So how much temperature you want to?
So, ma'am, room temperature of 25 to 27 degrees is recommended. But I think
For OT.
for OT, ma'am, even if it is lesser than that, that will suffice. But a higher temperature, because the generator itself gets heated up, is something that. So there's no recommended temperature. But let me just pull this up. So I think anything less than 25 to 27 is something which will not have a significant impact on the
Okay.
on the generator?
Ideally, Dr. Prabha, regarding the infection control, what they say is keep the temperature below 22 degrees Celsius.
Yeah.
If you walk into an ortho OT, you will freeze because they keep it around 16, 17, 18, though they will be all suited up. So ideally, if you're looking at the infection control, it's around 20. And to keep the generator cool, if you keep it around 20, 22, will be good for your generator life.
Correct. See, Rashmi, Dr. Rashmi,
Yes,
there's
ma'am.
only one they have to select or 2-3 options there?
Single best answer. Yes,
Oh,
ma'am.
single based answer. Okay.
So once the timer ends,
Okay.
I'll be discussing the answers as well. I'll just share the screen. In the meanwhile, the calculations will happen in the background with the help of Mr. Martin.
See, nobody knows this. They are patients.
So I have included a
See,
question.
if anybody has last year's, we have a published one focus, KSOGA focus on electrosurgical things.
Correct.
If anybody has read thoroughly that, because it was Ishwar sir has also written a chapter there, Sunil Ishwar sir. And all. If they have read that thing, they will be the topper of this quiz. It's a very nice.
Thank you, ma'am. Thank you, sir.
Thank you.
Which of this is not true? And I have written on electrosurgeries on various implants and other having implants and all. So you added that question also.
Yes, ma'am.
Dr. Rashmi, there is a kind of loop in that quiz. It's just moving backward and forward. It's not.
Versatile.
No, something went wrong in mine. It got closed prematurely. So yeah. Anyway, madam said no prizes to the committee members. So
No, you can solve.
I'll just share my screen if all of you are able to see. Yes, can you see my screen, madam?
Yeah.
Not.
No, once you press the link, then quiz ended. Only 5-6 questions.
Time up.
Okay, time up. Now, okay, you can.
Can you see my screen, madam?
Yeah, you can share, please.
I have.
Rashmi, not yet shared.
Okay. Just a minute.
Whether it will give a score also? No.
Yeah, it will give the score also.
It will give.
It has not given for me. Good, because it has ended.
Okay, I think there is some difficulty in sharing screen. I'll just read out the question answers. So in the electrosurgical,
you can share, I think. Priscilla?
Yes,
Arun is there? Arun is there?
I'll share
Arun?
the.
Yeah, I'll just change the setting for you.
Or I'll share the word format.
One second, Rashmi. I'll just make you the.
Can I put it in this one? Prabha madam, can I share it with you? You can share the screen, madam.
That's also fine.
Yes, ma'am. Just one.
No, but I need to. Or you can just tell the answers, no problem.
Yes, ma'am. So I'll share with you. If possible, you can just.
I'm on this thing actually. I'm on laptop.
You can share it on the message box here, Rashmi. I'll put it on the screen. In the chat, if you can share the.
Okay, we need to upload in that one. Yes, okay. So you need to upload it, madam.
Yeah. Just share that thing on the chat where, you have given me, but.
Yes, ma'am. Okay, so I'll read out the answers regarding the same. So one is the electrosurgery long loop. So that is used to complete the circuit of high density current. That is the correct answer. And about the percentage of surgical smoke that is made up of combination of all the chemicals, it is almost as high as 5%. With regard to all the components of surgical smoke, which of this is not true? So human papilloma and HIV have not been identified in it. That was not the correct answer. A gradual increase in the temperature of between the following degrees leads to simultaneous tissue desiccation and coagulation. The temperature was 60 to 95 degrees. And the incidence of laparoscopic electrosurgical injuries that we see per 1,000 procedures was 2 to 5. With regard to the use of electrosurgery in patients with cardiac implantable electronic devices, I think this is very important now. Which of these is not true? So use of high power cut mode to coagulate and short activation, that is the wrong answer. It should be the low power. And which statement is not true about the monopolar device? So use the highest possible power setting is wrong. It should be the lower one. Antenna coupling is nothing but when the active electrode, this cord, it emits the electromagnetic energy in the air, which is captured by the nearby device, inactive cord or the wire. This is called as the antenna coupling. And factors that affect increased lateral thermal spread are all except. It is a pulsed current is wrong. It is going to be the continuous there. And all the above things are true about the residual heat except ultrasonic energy instruments have lesser residual heat. This is wrong. They have more residual heat than the electrosurgical instruments. I hope all of you enjoyed the questions, though a little bit was there, but it is important for us to choose a winner, madam.
Yeah. Thank you. You have made this webinar very lively. And, attentiveness is also very important.
Yes, ma'am.
Thank you, Dr. Rashmi. Yeah.
Yes. So the quiz winner we have just received from Mr. Martin. He says it is Dr. Soumya P. And she has got 5 out of 10 correct. And she has taken 25 seconds to solve this.
Oh.
Congratulations. So Dr. Soumya P, you can just contact me on the WhatsApp number that I'm writing. So you'll be getting a certificate of appreciation. Thank you, ma'am.
Okay, thank you, Dr. Rashmi, and congratulations, Dr. Soumya P. Yeah, thank you.
Yeah, thank you, Dr. Rashmi, for that online quiz.
Thank you, ma'am.
Are there any questions from the audience for the speakers? I think we've had a very good discussion. I would like to take this opportunity to thank all our speakers, Dr. Anurag, Dr. Yamal, and Ms. Bhanupriya.
Yeah.
I would also like to thank all our chairpersons, Dr. Prema ma'am, Dr. Subhash sir, and Dr. Ishwar sir for having such a good clinical discussion. And thank you, Durgadar sir, for giving the endoscopy committee for this opportunity. Thank you all the office bearers of KSOGA for joining us. And thank you, Prabha ma'am, for idealizing this, that starting from the basics. So the second topic also was very clinically useful for all the students and practicing consultants. Thank you, KSOGA committee, for this opportunity to conduct the second webinar by the endoscopy committee. Thank you all.
Thank you, Dr. Priscilla. Actually, she is a MOC and she's doing very perfect job. Thank you for doing and taking the time for KSOGA. And see, one more thing, as we know that this is our second webinar, but we have declared that whoever attends the more than 80% of our webinars of endoscopy unit, they are going to get 3 months free training in our unit. So that chance will get reducing once the number of, our webinars go on increasing. They have to start attending from now only, then they can achieve that 80%. Okay. Whoever wants the free training. And thank you, sir. I thanks special Amal Patel, sir, who has taken his time. Actually, he is from Kenya. It is 5 hours almost back than us. And in our peak hours of surgical time, he has took time for us and given a wonderful insight. Thank you, Anurag also. He was in actually Eagle project, and in between here he's given us a time for our things. Thank you, Priscilla, again, and thank you, our President and Secretary of KSOGA.